Welcome to COVID Bite number 4. Here we'll talk about some of the ICU management, starting with the intubation and mechanical ventilatory settings. Of course, in the previous bites, we emphasized the importance of early intubation. Don't let the patients suffer, and intubate early versus late. Now, once on the mechanical ventilation, there are three things I want you to remember, three important things. Number one, if the patient has poor compliance, high elastance, then you would manage them according to the ARTSNet trial recommendations, which is basically low tidal volumes, 4 to 8 mLs per kg, ideal body weight, and keeping the PEEP a bit higher for recruitment of the stiff alveoli, trying to keep your plateau pressure below 30 and your driving pressure at 15 and no more. What's your driving pressure? It's that distending pressure that helps get the air into the alveoli. So basically the difference between end inspiratory and end expiratory pressure, which is plateau minus PEEP, basically. So you don't want that distending force to be too much, otherwise you're damaging the alveoli or over distending them. Maintaining high PEEP is preventing the alveoli from collapsing, so they don't do the shearing force of collapsing and reopening, which is damaging to the alveolar wall. That's it. That's all we need to remember from the ventilators. Now, Dr. Catanoni in Italy, and I have observed that as well, that our patients are not the typical ARDS you would get from like massive aspiration or, bacterial pneumonia, sepsis, pancreatitis, that kind of thing. Because I noticed that their aesthetic compliance is not bad. Some of them had compliance of like 45 and 50. And that is a little strange. So it's not one size fits all. Some patients have preserved compliance, and then you have to separate those two groups. Those patients with good compliance, there is no logical reason to use high pressures, whether high PEEP or. But for those who have poor compliance, at least what we know about the management of stiff lungs is try to be conservative on the volumes, tidal volume, so lung protective mechanics, low tidal volume, and permissive hypercapnia if you have to. We accept the pH in the 7.2s, the 7.25 is fine. If it falls below that, then you can also use some bicarbonate. Many of those patients do have some acute renal problems. The management in the ICU, you need to remember, we're not going to follow our regular path of liberal fluid resuscitation. Remember, when we used the targeted therapy, we used like 30 mLs per kg for fluid resuscitation. In COVID patients, it is emphasized that we do not do that. They don't do well with extra fluids. Use vasoactive medications early on. Try to sedate the patient, keep them comfortable. If they have dysynchrony with the mechanical ventilator, then they advocate also the use of neuromuscular blockades. Intermittent neuromuscular blockages or blockades are better than continuous infusion of neuromuscular blockades. Everybody was afraid, are we going to run out of ventilators with the massive numbers expected for this coronavirus? And then people started thinking ahead, am I going to have to use one ventilator for multiple patients? All these societies are ruling against that. As of yesterday, a good friend of mine, Dr. Alaa Gindi from Florida, called me and he said that now they are considering certain adaptive techniques or filters to allow several patients to benefit from one ventilator. But there were so many reasons not to do that, and I'm still not over this. Patients are different, and by sharing the same circuit, not only you're risking cross-contamination, but also complication rates. Compliance in one patient is different than the other. One patient might develop pneumothorax. One patient might be more or less sedated than the other. So there are so many reasons to advocate against the use of shared ventilators. This is a study that showed that less sedation and less neuromuscular blockade would allow patients to come off the ventilator quicker and more quickly, and then leave the ICU more quickly, which is like an old new fact that remains true. Now, is ECMO an option for patients with COVID ARDS? Well, obviously, COVID or no COVID, if the patient is not able to sustain life using his lungs, you're going to have to give them an artificial lung, which is what ECMO is. But you have to be very selective because that's a labor-intensive technique, and it needs a lot of resources. Not every center has this capability. So you have to be very selective. Only choose young patients with single organ problem, which is the respiratory. If they have multi-organ failure, then, or if they're old, then they're not going to be good candidates for ECMO, obviously. And if the patient spends more than 21 days on ECMO without reasonable cardiopulmonary recovery, then that's a futile case, and it's time to think about taking them off the ECMO machine. There are so many guidelines that I'd love to go over with you, but there is a lot of uncertainty as well. You know, the task force members would convene, and many of the issues are not voted on. People are just not sure because there is no evidence. So when there is no evidence, we're going to go with a consensus, a statement, and show you how the experts are voting on these things. Most of these recommendations from Surviving Sepsis Campaign guidelines are telling us how to manage sepsis in the ICU in the era of COVID or in COVID patients. And most of these recommendations, as you can see, are weak recommendations. So I'm only going to try to go through the strong recommendations and ignore the weak ones. One of the strongest recommendations is obviously the use of PPE, and we already addressed that in previous bites. I want to go back to that. And regarding the management of shock, we did speak about the IV fluid management, the starting vasoactive medications early. Avoid dopamine. Your best vasoactive medicine is norepinephrine. And that is also true for other types of shock. If the patient develops myocarditis or there's an echo evidence of myocardial suppression, then you would consider the addition of inotropes as well. Dobutamine is a preferred agent. The use of IV steroids, systemic steroids. If you're using them to improve ARDS from COVID, then don't. If you're using them for hemodynamic support, then yes. So if there is another reason to use steroids other than just the treatment of ARDS, pneumonia from COVID, then you would use the steroids for the other indication, whether it's shock or treatment of COPD, for example, and the patient is in need of the steroids. But if you're going to use it in the smallest dose possible. Now, oxygenation, you want to maintain your oxygenation closer to 96%. And that's a strong goal. And then the recommendations we talked about, managing mechanical ventilators, which is lung protective mechanics, small tidal volume. That's a strong recommendation as well. The management of PEEP and driving pressure, like we already addressed, are strong recommendations. The rest of the weak recommendations I'm not going to go through. Now, we used to use incremental PEEP for recruitment of alveoli, like a staircase type of recruitment maneuvers. The experts are recommending against this because the risk of barotrauma, valvular trauma is very high in these patients. And I personally had a patient who developed pneumothorax twice and required 2 chest tubes. Unfortunately, the patient is not doing well. Going again, weak recommendations. Now, in terms of management with medications and drugs, no one was able to give any recommendations regarding the use or the lack of use of medications. So as you can see, no recommendations made for the use of recombinant interferons, hydroxychloroquine, chloroquine, tocilizumab. And I will have a bite addressing therapy and what exactly is going on at our institution at UCSD and the ongoing trials. Like I told you, there are 5 different trials ongoing right now. And I'll tell you about the preliminary data we are learning from those trials. These are recommendations from a task force put together by the American Thoracic Society. So I put the green dots to show you that these are the things that majority of the experts said it's okay, go ahead and do it, because the preponderance of the evidence is leading towards use rather than no use. So now people are feeling more comfortable with hydroxychloroquine, azithromycin therapy. So as you can see, 73% of the experts are advocating the use of hydroxychloroquine. I personally, one of the units I work at in the Southwest University system, we put everybody in the unit on hydroxychloroquine. It is controlled by infectious diseases. One of the patients even got tocilizumab because of increased IL-6 level. I'm still watching to see what would happen to that patient, but I can tell you that I've seen some patients improve. I had one patient extubate, and I had one patient who is on minimal FiO2 now. Actually, I have two patients on 40% FiO2. One is on 50% FiO2, but we were able to come down on the PEEP to PEEP of 5. And 2 days ago, we started spontaneous breathing trials, but the patient needed a lot of rehab because now they're so weak, and I guess that's the limiting step. I have to share with you that radiographically, they have not improved a lot. There's some better aeration, but clinically, and PF ratio had improved, and they're now afebrile. So this is, again, anecdotal, and I'm not, advocating that you take my opinion on this, but it looks like the preponderance of evidence now is leaning more towards hydroxychloroquine. We have an ongoing study at UCSD for hydroxychloroquine azithromycin combination. Now, proning everybody, 99% of the experts say prone patients. And like I told you before, we're asking patients to prone even before they reach the stage of ARDS. Things you need to avoid is using hydroxychloroquine for outpatient management or for patients with upper respiratory symptoms without pneumonia, and even much less for prophylactic use. I know a friend of mine, he's actually Egyptian, who started taking hydroxychloroquine for himself as prophylaxis, along with zinc and vitamin C and all that stuff. I can't say right or wrong, but the recommendation is against that type of practice. Now, remdesivir is a different story. The preponderance of the evidence, at least in the Chinese studies, showed that remdesivir was able to bring down the viral loads, and hopefully we will see some clinical data showing that remdesivir is somewhat effective. Again, remdesivir works on the RNA polymerase, reducing the replication of the virus. So you would think that COVID is, after all, an RNA virus, and it is dependent on that enzyme to replicate. So if you can block the enzyme, like we did for SARS-1 and for MERS, hopefully remdesivir would have good results. But we have to wait for the results of the studies that are ongoing, and we have a study at UCSD with remdesivir. Lopinavir and ritonavir did not really show good evidence in reducing the viral loads, so I will leave those as out. Tocilizumab, if you have increased IL-6, then we are using that criteria in the Southwest University system to give tocilizumab with ID approval. But in La Jolla, where we have an ongoing trial with tocilizumab, led by Dr. Atul Malhotra, who is the former chair of pulmonary critical care at UCSD, there is restriction of giving the medicine unless the patient is randomized to the study. Because once an institution commits to randomization for a study, you're not free to give the medicine outside of the boundaries of the study. Anyway, last thing we addressed before, which is the systemic steroids for COVID pneumonia. It looks like most of the experts vote against that unless you really have another reason to use steroids. COPD exacerbation or maybe refractory shock. If you're using that for those indications, then it's okay. Otherwise, the recommendation is against the use of systemic steroids. I think this is a good place to maybe stop, and I have some protocols developed by several reputable institutions in the U.S., including Mount Sinai, University of Washington, Mass General Hospital, just to show you how people are thinking without obviously strong evidence from the randomized controlled trials, how they are approaching their patients with ARDS and how they are using these trial medications. Thank you, stay safe, and I'll see you in the next bite.